Dr. Boyer,
Hi, Kendra. What's up?
I just got off the radio with EMS. They're on their way in right now with a 24-year-old who was a motorcyclist who was involved in a down and under a semi-trailer, under a tractor trailer. He was unhelmeted. Right now, he's got some unstable vital signs. BP is 80 over 60, okay. Heart rate's in the 140s. He's breathing about 40 times a minute and has some really pretty noisy respirations. EMS has put an oral airway in, but they don't have anything else at this point.
Do they get an IV in him?
They do not have an IV yet.
So here's the plan.
Okay.
Is first thing before this patient comes is we need to make sure we got everything ready. It sounds like this guy's got an airway issue, so we're going to need to set up. I see we've got our airway stuff here.
Right.
Let's make sure we get a crike set because
okay.
It sounds like he's got some pretty bad head trauma as well. So when this patient gets here, here's the plan. We need to have a good organized team effort on this. First thing is we all need to make sure we put on our personal protective equipment. You said open femur fracture down here. He's not moving that foot, but he's moving the other one?
Correct.
And last blood pressure was 80 over 40, and he's tachycardic.
Correct.
Okay. Super. Anything else you want to tell me about him?
That's it.
Okay, thanks.
All right, thanks, guys.
Guys, let's get into action here. I'll tell you what we need to concentrate on. You're going to get a blood pressure for me. You hook over the monitor. I'm going to look at the airway here. You guys get that started. Let me see. I think I got my kit up here. Go ahead and bag him a little bit. You hook him up to a pulse ox while I'm doing this also?
Sure thing.
No, I'm not seeing anything.
I'll get the crike.
So, Kendra, do we have a crike kit? I think we're
I'll
going to
get that
crike
ready
this
for
guy.
you.
Okay, let's see. Okay, Cody, you keep us control there. Kendra, can you come over here and bag him? I'll get the kit set up.
I sure can.
Feel for the Adam's apple. Right below the Adam's apple is the cricothyroid membrane. We're going to make an incision. Down. Get a little blood there. We're going to use the back of our scalpel. I think I'm in the airway. Good. There's a little bit of air coming out there. And now we're going to put in a endotracheal tube. Actually, we have a tracheostomy tube here. Yeah, there it is. Kendra, can you hook that up there? What was his pressure?
He is now 80 over 60 still.
80 over 60 still. So
Heart
he's
rate's still
obviously probably
140.
bleeding somewhere. Let's give him 2 liters of fluid, wide open. You got 1 large bore IV. Let's start a second large bore IV in this right arm.
Okay.
The paramedic said he didn't have any pulses. Let me check those down here. Put some pressure on that for me, if you would, Cody. Thanks. Circulation, what's his pressure?
He is still 80 over 60.
80 over 60. And
Yeah.
how much fluid have you given him?
He's gotten the 2 liters of warmed IV fluid.
So he's not responding. Let's go ahead and give him some O-negative blood.
Sure.
Please give him 2 units of O-negative
Okay.
blood.
I
You
just
can hang
got
some
2.
more saline while you're at it.
Okay.
We've got our ABCs. Now let's do a disability exam here. So we're going to do a Glasgow Coma scale. We're going to see if he opens his eyes. Sir? It looks like he opens his eyes to pain. You know what that is? That's a 2. And he's kind of withdrawing to pain here. That's a 4. And right now he can't talk to me because he's got a cricothyroidotomy. So that's, what is that? 2, 4, 7. He's 7. So he's in a coma. So we're going to, it looks like he's got a depressed skull fracture there. He's got a Glasgow Coma scale of 7. We're going to need to send him to a neurosurgeon. So Kendra, when you get a chance, we're going to have to call the trauma center and get them on the line because we're going to have to move this guy.
Okay.
And then we're going to roll him. So we're going to need an additional body to help roll him also so we can keep C-spine precautions. So let's get that all cut off. Okay, guys, we've seen the front of him. Now let's roll him over and take a look at the back. We're going to need some extra hands to do a proper log roll.
And
You count it on 3.
Roll in 3, 2, 1, roll.
Okay, and I'm palpating the back here, looking for some step off. Okay. The prostate doesn't feel like it's, I can feel it, it doesn't feel like it's high right, and he's got good rectal tone. Let's get this thing out of here. Can you put those x-ray plates in for a chest and a pelvis for me, please? Okay, Liz, well, I want you to get a couple x-rays for me. Let's get a pelvis, a chest, and a C-spine film. Go ahead and develop those and bring them back to me, but when you come back, I'm going to have you get an x-ray of his femur. Okay, we got him exposed now. Let's cover him up so he doesn't get cold. Last thing we want is hypothermia. Now let's reassess our ABCs. So he's still hooked up to the ventilator. We're breathing at 12. What's his O2 sat?
97%.
97%, super. And he's gotten how much of that blood?
He's gotten 1 unit in and he's got the other unit halfway
Super,
in.
so we're making a little bit of progress there. Okay, we're ready to move on to our secondary survey. We're going to start at the top and work our way down. So let's take a look here at the head. Looks like he's got, oh goodness, looks like he's got a depressed skull fracture here. Pupils are equal and responsive. He's got a lot of crepitus in his face, a lot of swelling. Looks like he's got some facial fractures. Let's look at his neck here. Looks like his trachea is midline, our crike is in good place. His neck veins don't look distended. He's got a lot of abrasions here on his chest. And a little bit of concern. It feels like he's got some rib fractures here. And he's a little bit dull to percussion. He may very well have a hemothorax. I'd like to see that chest x-ray as soon as we get that back. Let me push on his pelvis here. Feels pretty stable. His abdomen, he's not really grimacing when I push on it. Doesn't feel like it's distended. I'm not too concerned about his abdomen at the moment, but it is a possible source of bleeding. Now let's look at his legs again. Those x-rays back?
They are.
Okay, let's see. Oh, good. We got him up on the monitor here. Looks like he's got blood in his chest. So he's going to need a chest tube.
Okay.
So we're going to clean this off real well. Now we're going to use some sterile towels here. Make sure you drape that off real well. We're going to make our incision about 2 centimeters in length. We're going to take a big clamp and actually stick it into the chest, right up over the top of the rib. Okay, now we're going to put the tube into the chest, and there it goes. And push this in till the last hole's in the chest. And we're going to hook this up to the thoracolex under underwater seal. And thank you, Kendra.
Thank you.
Okay, what do we got there?
Blood draining here.
A little bit of blood coming out, super. Take a listen to the breath sounds. And what's his blood pressure doing?
His blood pressure's up to 100 systolic right now.
Great. Heart rate's 120. He's gotten almost 2 liters of blood. He's got 2 units of fluid. Looks like we got all our x-rays. We got our chest, pelvis, our C-spine x-ray. We got that left wrist. We got the femur x-ray. It looks like he's getting ready to be packaged up.
Yeah.
Did you get the trauma center on the
Trauma
phone?
center should be on line 2 for you right now.
Okay, super. Let me go talk to them, and you guys get him all packaged up, ready to go. Great.
Great. Thank you.
I got a guy that I really need to send to you. He came to us minimally responsive. He had gurgling respirations and obvious facial fractures. We needed to do a cricothyroidotomy on him, which we did. The other things that he has, it looks like he's got some chest trauma, probably a pulmonary contusion. He had a hemothorax on the left side. I put a chest tube in. We've also noticed that he had a depressed skull fracture on that left side as well. And he's going to need a neurosurgeon when he sees you. He also needs an orthopedic surgeon. Super. I think he probably should come by helicopter, if you can send the helicopter.
Male.
Hang on. Wait a second. Hang on. I got to get the doctor.
Okay.
Hey, has anybody seen Dr. Boyer? Can you send him in here, please? We have a trauma. Dude, what's...
Hey, sir, how
What you got here?
Hey, you all right
24-year-old
there?
male,
You all right
motorcycle versus tractor trailer. Right now.
What did you guys do to him? Did you start an IV?
Skull fracture. Trying to
I
get
don't
IV,
see an
couldn't
IV in
establish
here
IV.
anywhere.
Okay, so what did he say his blood pressure was?
I don't know. I think he said it was around 100.
100, okay. Well, we got a little time to do some things
Yeah.
here, so
I'm
what's
going to just
going
go
on
ahead
here?
and I'll put him on a
Oh, there's a lot of blood
monitor
down here. Oh, man, that's... Oh, shoot. Christ, I just got this thing cleaned.
I'll tell them in just a second. Let me
Hey,
just
buddy,
do
how you
this.
doing? Well, he's opening his eyes. Looks like he's responding a little bit. So, let's see here. He's breathing.
Put your oxygen back on you there, sir. We don't want you
You
to
got a
get...
stethoscope?
I can't...
Here's one.
You have some scissors on you. I can't get anything over this, this
Okay, let's
shirt
see.
here.
Take a listen here.
Oh, there we go. Okay. Oh, there's some trauma scissors.
Can you put some pressure on that? It's bleeding an awful lot. Is ortho here yet?
I haven't seen them, but
Okay, can
let
you-
me
let's
let
call-
me just do this really fast.
So can you got a blood pressure or anything on him?
No, I haven't gotten that yet. Hang on for a minute. What's your name? You're not talking a lot up here, Dr. Boyer.
Well, he does look a little blue. You got a
maybe we
pulse
should
ox
put his
on him?
oxygen back on him. Yeah, it's not really picking up so well, though. Here.
Okay, well, maybe we ought to take a look at his airway here. Hey, sir, open your eyes. Let's get this thing off. I can't see his neck very well. Okay, well, he's got a little bit of bleeding there. Let's, got an oxygen mask here? Where's your oxygen
Oh,
mask?
where did that
Yeah, it fell
go?
down here.
Oh, there it is.
Okay, now let's bag him. Here, I'll tell you what. You just assist his breathing here and let him breathe. Here, probably want to do a 10 thrust on him here to do that. Okay, go ahead and start breathing for him. And you got
Oh,
a IV
his-
started yet?
I do. I got a 22 in his hand.
22. Okay.
Yeah. I'm just gonna put this D5
What is
and a
it?
half.
Yeah, that'll do for now.
All
Just
right.
give us a D5 and a half.
But
Don't run it too fast. I don't want to give him cardiac
don't want
failure.
to. Okay. I'll run it at
Um,
about 50 an hour.
It's kind of hard to bag, doctor.
Hard to bag. Gosh, maybe you ought to put it at oral airway back in.
Now, doctor, his heart rate's 140 and his blood pressure's down around 70.
70. You got that fluid. Let's put some more fluid here. You push
Okay.
on that.
Here, I'll squeeze that.
Okay. Is X-ray here yet?
I don't know. Let me call out. Hey, Julie, can you see if X-ray can come into trauma?
Let's see. His pupils look okay. He's got a bunch of He's got a bunch of fractures. It looks like, and gosh, it looks like there's a big hole in his head here. There's blood coming out of there too. Careful, you might get squirted. Gosh, I can stick my finger almost into his brain. It's got
Oh,
a hole there.
my.
It looks like a depressed skull fracture. We probably ought to send him to CT scan. Can you call the CT tech in? I think they're not in today, but you can call them in. Does he have a pulse?
I don't really feel a pulse.
Are you breathing for him?
Oh, sorry.
You don't feel a pulse?
I don't really feel a pulse.
I'm not really feeling much of
I must
anything.
have pushed pretty hard.
You know how to do
there.
CPR? Why don't you start pushing on his chest here, okay? And let's see, we got to breathe for him.
I don't know. Should I give him some atropine or something maybe?
Will we have some dopamine?
I can mix some up.
Yeah, let's
let
get
me
some
let me run
dopamine.
and get some of that.
Okay. Are you doing effective compressions there?
Well, I'm pressing pretty hard.
Okay. You got any suggestions?
Did we stop the bleeding?
Looks like it. He's not bleeding now. No, I don't think we're going to make this one. I don't think he's going to survive.
I don't feel a pulse.
Well,
Just call it.
let's call it.
All right. So the time of death is 14:38.
Yeah, this is a little disappointing, Kendra. This is the third one this week. You know,
No,
it's
a
around a
tough
bad,
run, Dr.
bad
Boyer.
run.
Really tough run.
To remove the helmet from a fully immobilized helmeted patient, you will need at least 2 people. We would start by removing the head and C-spine immobilization from the board and replacing that with stabilization by the first person. The next thing that would be accomplished would be removal of the chin strap of the helmet. The second person would then take over head and C-spine immobilization, while the first person stretched the helmet to remove it fully from the patient's head, being careful not to move the patient's neck. Once this had been done, the C-collar can then be applied to the patient in quick sequence, again, maintaining immobilization with reversal of roles from the first person to the second person, securing the collar snugly under the patient's neck.
Some of the hallmarks of a good intubation include making sure you're prepared. You want to make sure all your equipment is ready to go. We've talked about ensuring that the laryngoscope blade is well lighted, the batteries are fresh. You want to make sure that you have oxygen flowing to your bag device, making sure that your cuff on your mask is inflated. And when you want to have your patient in the best prepared position, by getting them very well oxygenated before you try your attempt. This involves maybe a little hyperventilation so that you can pink them up a little bit, because they're not going to be breathing the whole time that you do your intubation attempt. Likewise, after you've had a successful intubation, you want to make sure that you are in the trachea. And there are several devices that we can use, as well as making sure we visualize the tube going through the cords, make sure that we watch for rise and fall of the chest. We auscultate, and it's 3-point auscultation over the right left and over the belly to make sure we don't hear borborygmi there. Then you can use extra devices. One is our end-tidal CO2 device. We want to make sure we see the change from the dark gray into the light sunshiny yellow. Likewise, we can use an esophageal intubation detection device. You place this over the tube, depress, and it should flow and open up easily. If the bulb stays suppressed, then you know you're probably in the esophagus. We also have electronic measures that are useful in verifying that we are successfully in the trachea. We can use pulse oximetry. The nice thing about pulse oximetry is it gives you continuous feedback so you can monitor as things improve. It also lets you know if perhaps the tube has been displaced. Additionally, your facility may have the ability to do capnography as well. A second adult airway adjunct is the oropharyngeal airway, a more rigid device used in patients whose level of consciousness has obliterated their gag reflex. A little bit of rotation, and then rotate 180 degrees until it sets in. The other way that you can handle this is either using a laryngoscope blade or a tongue blade to hold the tongue out of the way, sweeping it to the right and going straight in with your J-tube. Then you'd want to go ahead and start bagging your patient with the bag mask device. When establishing an airway in the infant, we follow the same basic procedures as we do when establishing one in an adult. The airway can be maintained with an oral airway. One difference in pediatrics is we want to make sure that we use an adjunct like a tongue blade to move the tongue out of the way and place the J-tube straight back, sealing it in the oropharynx. Then the mask is placed over the nose and mouth, sealed, and you start bagging. Using the pediatric equipment, of course, so that you have the pop-off valve to make sure that we don't overinflate and cause barotrauma. This will be the great way to make sure that infant stays resuscitated and the airway is maintained while you get all your equipment ready to do a full intubation. The skills required to ensure that the adult airway is maintained are critical for a successful resuscitation. One of the easiest and best tolerated by an awake patient airway tools is the nasopharyngeal airway, a soft rubber device. Once you coat with a little bit of lubricant, you warn the patient that they'll feel a little bit of pressure in the nose, and the placement is straight back along the floor of the nose. And the airway seats very comfortably. This gives the patient a little bit of extra margin of safety in that if their level of consciousness is waxing and waning, the airway is maintained with this. Yet it doesn't cause any gagging. Securing the adult airway during our resuscitation is a critical part. We want to make sure that we have a tube in the trachea with the cuff inflated. That's the definition of a secure airway. As you prepare, you want to make sure all your equipment is ready to go. The laryngoscope is powered, bulb is working. Endotracheal tube with a stylet in place. The tip of the stylet, of course, recessed from the end of the tube. Inflate your cuff to make sure that it's working. Suction is available as well. Normally, your resuscitation team would be bagging the patient. When you're prepared, the guideline is for the provider to take a deep breath and hold it just as your patient will be holding the breath as you prepare to do your intubation. With the head slightly tilted, making sure that suction is applied so all the secretions are out of the way, the laryngoscope blade is introduced, the tongue is swept to the right, and the elevation on the laryngoscope blade goes up and away from the patient, not cranking on the teeth. Visualizing the cords, I place the tube and watch the cuff go inside the cords. Stylet comes out, cuff is inflated, and patient is ventilated. Watch for rise and fall of the chest, and then auscultate to hear breath sounds on each side with no borborygmi. An additional device is the end-tidal CO2 monitor. Once the patient has been intubated successfully, this device allows you to double check and make sure that you're in the trachea. By placing this device between the endotracheal tube and your bag, you're able to watch for a color change that occurs that witnesses the CO2 level rising with your resuscitation. Normally the color is purple when it comes out of the bag, showing low CO2 concentrations, and you expect to see this change from purple to tan to yellow, letting you know that you have successful intubation. Sometimes during resuscitations, adults will present a very difficult intubation situation. In such a situation, perhaps an obese patient or someone with just a very short neck, it'll be very difficult to get a good view of the cord. We have an adjunct that can help in intubating a patient like that. It's the gum elastic bougie. The tip here is designed such that when you place it, the anterior deflection will naturally guide into the trachea, and the sensation that one feels as the tip goes through the cords and strikes against the rings of the larynx is very characteristic. It's nothing like that. Once it's in place, then you simply slide your AT tube over. You follow your same endotracheal guidelines, making sure your equipment is ready, suction is available. Sweep the tongue to the side, visualize the cords as best as possible, and then slide your bougie just past. If you can't necessarily see the cords, you can then feel the clicking that occurs as the tip of the bougie hits the cartilage rings. Once it's in place, simply slide your endotracheal tube over, using it as a guide. Your bougie comes out. You inflate your cuff. Start bagging, watching for rise and fall of the chest, and listening for lung sounds on both sides. One of our other adjuncts to ensure that the airway is maintained in our trauma patients is known as the LMA, the laryngeal mask airway. The idea here is you're able to insert this blindly. You don't have to find the cords with the laryngoscope. By sliding this in blindly, it lodges up against the airway, you inflate the cuff, and it seats itself securely there. Ideally, you'll have time to make sure your patient is well ventilated before you begin this attempt. The same rule applies. Take a deep breath just as your patient is doing. I feel some resistance. Stop. Inflate the cuff securely. Sometimes you'll get a little bit of regression once you know the cuff is seated. And start your bagging. You'll follow the same protocol. Watch for rise and fall of the chest as you do this. Auscultate both sides to make sure you hear breath sounds on both sides. As you prepare to do the endotracheal intubation with the pediatric patient, you want to make sure your equipment is ready and in working order. Laryngoscope blade checked. Have your tube ready to go with a little bit of jelly on it so it'll slide easily. Whoever's helping with the resuscitation, of course, will make sure that the patient is fully ventilated. Remove your oral airway. Sweep the tongue from the right to the left, visualizing the cords. Using the uncuffed tube, watch the tip of your tube go right through the cords, a couple of centimeters past that, and watch for rise and fall of the chest. You'll want to auscultate afterwards to make sure. No sounds in the stomach, good breath sounds on both sides. Then you'll need to secure the airway in place with either a commercially available device or taping. Sometimes, due to trauma considerations, you won't be able to get an endotracheal tube into the airway. And perhaps there'll be so much trauma that you won't be able to get a good seal with a bag mask device. You'll need to get a surgical airway. The most common one that we do in a resuscitation effort is called the cricothyroidotomy. You find the laryngeal notch here, which is just below your Adam's apple. The cricothyroid notch is a thin membrane that allows for quick incision with minimal blood loss. You'd want to clean the area with your antiseptic. Betadine is a great choice, of course. The incision is horizontal, right across, relatively superficial. You can widen it with a little blunt dissection with your forceps. Your tube is already set, ready to go, placed in and just past the cuff. You don't need to put in as much as you normally would. Inflate your cuff and begin ventilating. You'll have the same criteria to watch for successful intubation. You want to see rise and fall of the chest, then auscultate both sides as well. Then you'll want to try some of your other devices to confirm placement. Providing oxygen for the trauma patient is a critical concern. One of the easiest ways to do that in the resuscitation area is with the bag mask device. In this patient, I've already placed an oropharyngeal airway. I make sure that my mask fits comfortably over the mouth and nose, and then I get a good seal by grasping the mask and securing it by holding on to the mandible. I have my mask, I have my bag, and the oxygen supply is attached. I start with deep, slow, full respirations. With a good seal on the face, I watch for rise and fall of the chest. Ideally, we'd have pulse oximetry on at the same time, so I'd want to watch to see an increase in the pulse oximetry. Physically, this is a little bit of a difficult task. It is best done if an assistant can provide another pair of hands to do the bagging while one person holds the mask in place.
Landmarks for a surgical airway would include the thyroid cartilage, the cricoid cartilage, and between the two of them would be an indentation, which would be the cricothyroid membrane. We would like to make a transverse incision across the cricothyroid membrane and then dissect directly down into it to insert our airway. Landmarks for the needle decompression of a tension pneumothorax would be the third intercostal space. A way to find this on the patient would be to locate the angle of Louis and go laterally about mid-clavicular line, and this is where the needle would enter to the superior aspect of the rib itself in the third intercostal space. Landmarks for a chest tube are generally the fifth intercostal space, and the ribs can be palpated. This is generally in line with the nipple, but on a somewhat more corpulent patient, you may need to use a hand to find this landmark. And at all costs, we do not want to put a chest tube through a previous wound. Landmarks for a diagnostic peritoneal lavage, generally we would be going directly below the umbilicus in a vertical manner. There are several caveats to go above the umbilicus if the patient is pregnant or has had previous lower abdominal surgery. Landmarks for IV access. One vein would be the basilic vein, which would be found on this patient right here, approximately 2 finger breaths from the olecranon process and 1 finger breath from the antecubital fossa. That would be right there. Landmarks for the saphenous vein would be 1 finger breath above the medial malleolus and 2 finger breaths cephalad. Again, marking the saphenous vein right there. It's very easily palpated. You may roll it between your fingers. For the cut downs, we would like to do a transverse incision, being careful not to go through the vein on the first cut, but giving us room to go medial or lateral to find the vein in case we have not correctly identified the landmarks.
The next skill we'd like to demonstrate is the venous cut down. The venous cut down is a very important part of the armamentarium when taking care of the traumatically injured patient. As we previously described, there are 2 places on the body where you can do the cut down, on the medial aspect of the ankle and also at the elbow, as we demonstrated on the landmarks previously. There are several things that you want to make sure you have prior to doing a cut down. You want to make sure that you have the proper equipment. Things that you need at your disposal are a number 15 blade, a number 11 blade, you want an angiocath, or occasionally, alternatively, you might actually use the end of an IV tubing to place within the vessel. You're going to need a pair of scissors, a couple of mosquito clamps, and some 2-0 silk. So once again, the way this procedure takes place is you want to identify the landmarks. And if you recall, the landmark on the ankle is on the medial malleolus. You're going to go about 1 finger breadth or 1 centimeter above and 1 centimeter medial to this, and this is where you should find your saphenous vein. First thing you're going to do is make sure that you clean off the area with some betadine. You're then going to make an incision of about 1 to 2 centimeters using a 15 blade over where you suspect the vessel is going to be. And you want to be careful not to carry this too deep, as you can actually damage the vessel prior to finding it. So you can carry this through the skin and the subcutaneous tissues. Once you've made your incision through the skin and subcutaneous tissues, now the key is to take your mosquito clamps, pushing down against the bone and trying to run in line with the vessel right against the bone. And what this does is actually divides that subcutaneous tissue. The goal here is you're trying to isolate the vein on either side. And so I'm spreading on either side of where I think the vein is here. And I'm actually beginning to see it come into view. And now what I'm going to do is use the mosquito clamp tips and turn them over 180 degrees and come under the vessel next to the bone and try to hook the vessel, as you can see I've done in this picture. Now I've got the vessel up, and now the key here is you want to take a silk suture and actually pass it on either side of this vessel. One trick I like to use here is just to use 1 piece of silk folded in half, taking the center of that and pulling it through on both sides. Now I have this looped silk through. I'm going to cut it, and now what I have is essentially 2 pieces of silk, one above and one below. Now you're going to want to tie the end that's down at the ankle because you want flow to go towards the head. So I'm going to tie this down. And the next step here is you want to make sure that you cut the vessel at a kind of an angle, but not completely transect the vessel so that you can get the IV into it. And one of the tricks that you can do for that is, if you imagine that this piece of IV tubing is the vessel, you will place the 11 blade perpendicular to the vessel, going from one side to the other, as you see here, and then angling it up and out towards the foot. And what this does is raises a flap that you can then effectively place your IV into. Okay, let's do that on the vessel. At this point, it's useful to have an assistant who can hold on to the suture for you on your vessel. And I'm going to grab the other end of this and bring the vessel up into my field. And now I'm going to place the 11 blade perpendicular to the vessel, through and through to the other side, and then angle it up and away. And now you see I've raised a bit of a flap there. And through this flap, I can now place my angiocath, aiming it up towards the head. Relax a little bit. And now that's in the vessel. I can now place my IV tubing to this and tie this in place. And we now have a functioning line at the ankle that we can deliver high volumes of fluid to.
The provider may want to use the interosseous route. The interosseous route allows a quick, relatively innocent way to get fluid on board. When setting up, you want to make sure your equipment is ready to go, your trocar is set, you have your antiseptics, and your fluids set up. The patient area is defined as the anterior plateau 1 to 2 finger breadths below the knee. Using betadine to cleanse the area. Introducing the trocar by using a drilling motion back and forth, firmly going through until you feel the needle pop through the cortex. Remove the trocar. Aspirate to make sure that you get marrow back. Once you see that, you know you're inside. Apply your fluids and continue with your resuscitation.
The next procedure we're going to talk about is the chest tube. It's a given that when you do these procedures on the chest that we're going to prep widely. We're going to prep from the base of the neck all the way down to the pubic bone and then from side to side on the chest. Once again, if you recall, the landmarks for the chest tube are going to be the 4th or 5th intercostal space. And we use in the male the nipple, or in the female the inframammary crease. And in patients in whom this anatomy is a little bit distorted, you can also take your hand and put it in the axilla, and the bottom of your hand is about the 4th or 5th intercostal space. If the patient is moribund or comatose, you probably don't need to use local anesthesia, but it's probably a good idea to use local anesthesia in patients who are otherwise conscious. The chest tube procedure is something that every physician needs to know how and master, because this is something that you can save a life with. In fact, 85% of all penetrating trauma to the chest and blunt trauma injuries can be treated with just a chest tube alone. Indications for a chest tube are going to be such things as a simple pneumothorax, a tension pneumothorax, or a hemothorax. If you have a tension pneumothorax, you're going to preclude the chest tube by putting in the needle thoracentesis, which we taught you earlier. Obviously, you want to make sure that you prep this area widely. You're going to once again reaffirm your anatomical landmarks, which are going to be the 4th or 5th intercostal space, approximately right here. If this patient is somewhat aware, it's good to put in some local anesthesia, but we'll assume that this patient is comatose and doesn't need it at this time. If your patient is awake or conscious, it's a good idea to use some local anesthesia, as this can be a very painful procedure. Generally, we like to use some lidocaine with epinephrine, and we're going to infiltrate the skin over the area of the landmark, which is about the 4th or 5th intercostal space, just anterior to the mid-axillary line. I'm going to raise a little bit of wheel. I usually like to go down right on top of the rib that I'm going to be making my incision over. I'm then going to take a 10 blade, make an incision approximately 2 to 2.5 centimeters in length over the rib, right down onto that rib. Now what I like to do is actually verify I'm on top of that rib. I can feel that rib underneath my finger here. I'm then going to take my anesthesia and infiltrate a little bit more anesthesia on top of the rib. The other key point here is you want to go on top of the rib, not under the rib, because the neurovascular bundle is under the rib and you'll cause intercostal bleeding if you do that. The other key here is to use a large clamp. Because we're suspecting in trauma that there's blood, we always want to use a fairly large tube, at least a 36 French tube. And if you look at the chest tube has several holes in the end of it, and that last hole breaks this white line. This white line shows up on an x-ray, so if you look at an x-ray, you can tell where that last hole is in relationship to the skin. The other little trick here is that you want to make sure when you're putting this in for suspected blood is that you clamp the end of the chest tube, because if you stick this into the chest and there's blood in the chest, it's going to come out all over your shoes. So we've got our chest tube ready, we've got it clamped. Now we're going to go ahead and put our finger back on the bone and feel it. We now can feel the bone underneath our finger here. We're going to take another large clamp. You're going to go directly over the rib that you put your finger on a moment ago, and you're going to push up and over the rib and into the chest. And this maneuver requires a substantial amount of force if done properly. And you generally will feel a large pop. The thing here is in a young, healthy, muscular patient, this can require quite a bit of effort. And so don't feel nervous about pushing too hard. Once you've done this, you want to then spread, close your clamp a little bit, spread again. The idea is here you want to make a hole large enough that you can put both your finger in, first of all, and then this large tube once you're done. I now have a hole in the chest. The next step is to take and put my finger into the chest, confirm, number one, I'm in the chest. And in the patient, you should be able to feel the lung up against your finger. Also, the reason for putting your finger into the chest is to sweep your finger around inside the chest to make sure there's no lung adhesions with the lung stuck up against the chest. Because even if the patient has a pneumothorax, he can still have adhesions up against the chest wall, and you can cause additional damage to the lung if you don't sweep down these adhesions. So now we've confirmed we're in the chest. We can feel the lung under our finger. And now the next step is to actually insert the chest tube. So now there's a couple of different ways of doing that. You can actually try to put the tube in directly, but I think many people find it convenient to take your clamp, put it on the end of the chest tube, and then try to follow this track right back into the chest the same way you went before. You can see I'm going into the chest. There's the last hole. My goal now is to have this go in a posterior direction, laying along the back of the chest wall towards the apex. So that last hole's going into the chest. I'm advancing it. And I usually advance this till I feel a little bit of resistance. That tells me I'm bouncing off the apex, and then I pull back a slight amount. So this is 1 or 2 centimeters from the apex. Now that the chest tube's in place, we're going to go ahead and sew it in. Generally, you want to use at least an O silk. You're going to create a suture on either side of the incision. Taking a nice generous bite. The goal here is you're going to want to secure this tube in place so it doesn't get pulled out, particularly if this patient is going to be transferred somewhere else. You want to make sure you secure it firmly. So we're going to tie this down. And then we want to fix this firmly around the chest tube. The way I like to do this is to actually create a half hitch on one side of the tube, and then using the other suture, create another half hitch, as you see, and then pull opposite on either side of those tubes so it now indents that tube. And while holding this under tension, I can now tie this down securely. And the tube is fixed to the chest wall and not likely to come out. We then cut the suture. And then the key point here to complete this is you need to hook this up to this underwater suction using this chest tube apparatus, collection apparatus. And this has been hooked to the wall with minus 20 millimeters of suction. We then take the end of this, plug it into the chest tube, release the clamp, and you should see either blood or air come out of this if you put this in for the right reason. At this juncture, you will now put a dressing on this and tape it to the patient's chest wall. The pericardiocentesis is a procedure that's not often done for traumatically injured patients, but does have important uses in certain circumstances. If you suspect a patient has a pericardial tamponade and is showing tamponade physiology, and you're not a surgeon, then oftentimes it's important to be able to needle the pericardial sac and relieve that pressure from around the heart. The way to do this is to make sure you have an adequate length of your needle. The needle has to be at least 3 inches in length to reach the pericardial sac. Important landmarks that you need to consider are the xiphoid process, and you want to go just below the xiphoid process, just a little bit to the patient's left of that xiphoid process. You're then going to angle your needle at a 45-degree angle, aiming towards the patient's ipsilateral nipple or the tip of the scapula on that side. Aspirating as we go. One of the things you want to do is watch the EKG at this point, or have someone watch it to see if there's any ST depression. And here you see a positive tap of pericardial fluid coming out. At this juncture, you have a couple of options. You can pull the needle out at this point, but if you suspect that the pericardial fluid is going to reaccumulate, you can actually put the angiocatheter in there and put a 3-way stopcock on it so that it can be periodically reassessed. And so at this juncture, you're going to put a 3-way stopcock on this. and be able to re-aspirate should the patient reaccumulate pericardial fluid. The diagnostic peritoneal lavage is a technique that has fallen somewhat out of disfavor in trauma circles as the FAST exam has replaced it. But there will be times when you don't have ultrasound available and you'll need to determine whether or not a patient has blood in the abdomen. The DPL is, or diagnostic peritoneal lavage, is designed specifically for that. The idea is if you have a patient you suspect has blood in the abdomen, is that you put a catheter underneath the umbilicus into the abdomen and then withdraw fluid. If you get blood back, that's considered a positive tap if it's more than 5 cc's of blood. If you don't get blood back, then what you do is you put saline into the abdomen and then slosh that around so that it goes through all the abdomen cavities. And if there's blood in there, it will contaminate that fluid. You then drop the bag to the floor, and if blood comes out of greater than 100,000 red cells or more than 500 white cells per cc, this is considered a positive tap, and the patient needs an operation. Additionally, if you get back intestinal contents or food particles, that's also considered a positive tap. There are two different ways of doing the diagnostic peritoneal lavage. There's the closed technique using a needle and a Seldinger technique, and there is the open technique. First, we'll demonstrate the closed technique or the Seldinger technique. There are commercial kits available to do this, and most of these include a needle with a wire and an angiocath, as you see here. And the idea here is that you're going to advance this needle through the abdominal wall. You will feel a pop as you pop through the anterior fascia, and you'll feel a more subtle pop as you pop through the peritoneal structures. The other idea here is that you want to go below the umbilicus and aim towards the pelvis, because if you remember, the bifurcation of the aorta is right below the umbilicus. If you aim directly toward that, you may get a positive arterial blood gas that you don't want. The only time you wouldn't go below the umbilicus is if you suspect a patient has a pelvic fracture. You're going to want to go above the umbilicus because if you recall, the retroperitoneum actually comes forward to just below the umbilicus, and if you do your diagnostic peritoneal lavage there, you're going to get a false positive tap. Additionally, if the patient is pregnant, the uterus will displace the abdominal contents upwards, and you don't want to stick the needle into the uterus. You're going to want to go higher in the pregnant patient. So once again, the closed diagnostic peritoneal lavage is you're going to aim the needle down towards the pelvis, and you're going to feel a pop as you pop through the anterior fascia, and you're going to feel another pop as you pop through the peritoneum. You're going to then aspirate, and I'm not getting anything back at this moment, so now what I'm going to do is actually going to pull the needle out of the angiocath, and we're going to do the Seldinger technique using the wire. The wire is going to go into the angiocath, and it's going in nice and easily. If you meet resistance, you're probably not in the pelvis, and this needs to be repeated. You're going to place this in until you have a few centimeters left hanging outside of the angiocath. Going to remove this dilator. Now, the angiocath comes out, leaving the wire in place. We're then going to make a small nick next to the wire using a number 11 blade right next to the wire, making a hole big enough so that our catheter will go through this. We now are going to put in the catheter. This diagnostic peritoneal catheter, which comes in this kit, has holes all the way around it, coming up about halfway. Once again, anytime you do the Seldinger technique, you want to make sure you have more wire than you have length of your catheter so that you don't lose control of the wire and it ends up in the abdomen. So we're going to go ahead and put this in and thread it in over the wire. Maintaining control of the wire both below the catheter and above the catheter. Now I have the wire up above and below, and now I have control of the wire up above. And now what I do is I actually insert the catheter using a kind of a spiral downward motion, advancing it into the abdominal cavity. And this is going nice and easily, and once I have this in place, the wire comes out. And then I aspirate to see if I have blood in the abdomen. And I'm aspirating and I'm getting out blood. You can see I have about 8 cc's of blood that's come out of this tap. This constitutes a positive tap, and this patient needs an exploratory laparotomy. If in fact I had gotten no blood out, as you see here, then the technique is to put fluid into the abdomen. And you're going to take warm saline. You want to use warm saline because you don't want to make the patient hypothermic. And generally, this is going to be based on the patient's weight. If you have a very small patient, you don't want to put the entire liter in. If you have a large patient, you're going to put more fluid in the abdomen. Generally, you're going to use about 10 cc's per kilogram. So for the average 70 kilogram man, you use about 700 cc's of fluid. So we're going to take and put the saline into the abdomen, and we're going to run this bag of saline into the abdomen. The key point here is if you let all the fluid go in, you're not going to be able to get it out. Now, if you've ever siphoned gasoline from a car, which is becoming more common these days, if you recall, if you don't have any fluid in the tube, you cannot get it to come out when you get to the end. So you're going to put in about 700 cc's of this warm saline, then drop the bag to the floor and see how much of this fluid comes out after you've sloshed it around inside the abdomen. We'll now demonstrate the open surgical technique for diagnostic peritoneal lavage. This technique requires two people to do because you need an additional set of hands. While we're getting our stuff together, we'll talk about some of the complications and contraindications to doing this procedure. If you have a patient who has had prior abdominal surgery, a diagnostic peritoneal lavage is relatively contraindicated because you're not going to be able to distribute the fluid in the abdomen. Likewise, if you have a patient who needs an operation already, you know he's got a gunshot wound to the abdomen, or his abdomen is expanding in front of your eyes and he's hypotensive, he doesn't need a diagnostic peritoneal lavage. He needs to go to the operating room. Patients in whom you would like to do this procedure are patients in whom you can't really figure out what's going on in the abdomen. You suspect it, but you can't figure it out. A patient who has a head injury, a patient who is under the influence of drug or alcohol, a patient who is unconscious is not going to be someone who can tell you whether or not their abdomen hurts, and you're going to want to do a diagnostic peritoneal lavage to rule out intra-abdominal hemorrhage. The open DPL is technically a surgical procedure, and so this needs to be done sterilely. You need to make sure that you've thoroughly prepped the abdominal wall, and you also want to use some local anesthesia if you can. Remember, we're going to go below the umbilicus unless this patient is suspected of having a pelvic fracture or is pregnant. So we're going to go below the umbilicus in the midline. We're going to raise a wheel using some lidocaine with epi. And it's very important to use lidocaine with epi because you want to minimize bleeding from the skin so that you don't get a false positive tap. We're then going to make an incision about 1.5 to 2 centimeters vertically below the umbilicus. And at this juncture, it's useful to have an assistant. And where I'm going to go ahead and spread with my clamps one direction, my assistant will spread the opposite direction. And the idea here is we're trying to find the fascia, the external fascia. And it looks like we're getting down to it. Spread just one more time for me. And now we're going to put in some retractors. Usually Army-Navy retractors are very good for this circumstance. Now that we have the anterior fascia exposed, we're going to want to incise the anterior fascia in the midline using the knife. And here you see it being incised. And what should come into view is a little bit of properitoneal fat. We're now going to spread this properitoneal fat, looking for the peritoneum. So I'm spreading this fat both ways. And now I'm going to try to grab the peritoneum. And there you see I've got a hold of peritoneum. We're going to grab that with an Alice clamp on either side. There's one side. And we can see that's a little blood tinge, so that's a little suspicious there might be some bleeding in the abdomen, but we need to confirm that. So now we've got this peritoneum. We're going to take a pair of scissors, make a small nick in the peritoneum so we can put the catheter in. Make sure we're in the peritoneum. And relax on that a little bit. There we go. There we go. We have an opening in the peritoneum. And now we're going to take our catheter. The catheter is going to go into the abdomen. Once again, we want to aim down towards the pelvis. And we put this in nicely, easily down into the pelvis, and we're going to aspirate. And once again, this will be considered positive if we get more than 5 cc's of blood out. Now the catheter is in the abdomen, we're going to aspirate. And as you see, this looks like a positive tap as there's about 10 cc's of blood coming out. If this tap were negative, once again, we would attach the IV tubing to this and run in about 700 cc's of warm saline into this patient. We're running that in widely, and it looks like it's running nice and wide open. We're now going to slosh the abdomen around a little bit to allow the fluid to get into all the spaces of the abdomen. Now we've got about, as you can see, about 700 cc's of warm saline in the abdomen. I'm not going to take this bag and throw it onto the floor, and I'm going to let the fluid run out of the abdomen onto the floor, and there's some fluid coming out. We'll let that come out for a little bit. Now the question is does this patient need an operation? Well, we need to send this fluid to the lab to see what the cell count is. If there's more than 100,000 red cells or more than 500 white cells per cc, then this patient would be considered to have a positive TAP and would likely need an exploratory laparotomy.
To accomplish a modified log roll maneuver to fully examine the patient and see their back, you will need at least 4 people. You will need 1 person to maintain inline stabilization of the head and neck. You will need 1 person to maintain control of the shoulder and the hip. You'll need a second person to cross with the other person maintaining the torso control to control the hip and the lower extremities. The person maintaining control of the head and neck controls the maneuver.
Prepare to roll. Roll.
Once the patient has been rolled, the back of his neck as well as torso can be examined, as well as buttocks crease, and remainder of lower extremities. This is also a good time to do the rectal exam. The board is then removed for patient comfort and safety.
Prepare to lower. Lower.
The traction splint requires 2 people to apply it. The first step in applying the traction splint is to measure it against the uninjured leg. So in this situation, the left lower extremity is the intact extremity. The traction splint is measured for length so that it's up against the pelvis, and distally has several inches to clear the ankle. The length is adjusted by unlocking with these knobs here and then tightened in place once the appropriate length is in place. In the meantime, the second person will be assessing the pulse in the injured extremity and stabilizing the injured extremity manually. The ankle hitch can be applied at this point in time, and then the extremity is carefully pulled and supported with traction to stabilize and realign the fractured femur. The injured extremity is supported, and then he is pulling traction on the injured extremity to realign the fractured femur. The splint is slid up into place up to the ischiotuberosity. The extremity is gently placed down with traction still applying, manual traction, placed down in position. The ischial strap is fastened first. And tightened. Next, the ankle stirrup is attached through this loop. And the ratchet is used to apply mechanical traction while watching the femur fracture, the realignment. After adequate alignment is achieved, the pulses are checked again. The rest of these straps are then applied, 2 above and 2 below the knee. patient is then ready for transport. Pelvic fractures can be life-threatening because of the amount of bleeding that can occur. This is particularly true for so-called open book pelvic fractures, where the pelvis widens and the volume is increased. This allows for more potential space for blood to fill, and that can result in life-threatening hemorrhage. One method to potentially reduce this volume is to close the pelvis down. This can be done with a variety of means, such as surgically with an external fixator, or in the emergency department setting with either using a sheet to make a pelvic sling, or as commercially available pelvic binder as we have depicted here. Using this commercially available binder, you want to first size the binder and carefully position it underneath the patient, such as we have depicted at this point. Then there's some Velcro type straps to place the binder in position. Then an assistant will come in and at this point push on the pelvis to close it down while using this device to cinch it up.
The focused abdominal sonogram for trauma, the FAST exam, is used to look at specific locations in the abdomen for blood. The first location is the subxiphoid window, measured right at the xiphoid process, aiming up to get a good view of the cardiac shadow to eliminate the diagnosis of pericardial tamponade or pericardial effusion. An additional window may be used in the peristernal area to get an additional view of the heart as needed. The right upper quadrant is then imaged at the inferior aspect of the rib cage to find the liver and kidney interface. The left upper quadrant interface, much the same at the inferior aspect of the rib cage to find the spleen and kidney interface. And finally, the suprapubic window, right above the pubic prominence, to find the bladder, looking in the pouch behind the bladder to exclude blood as well.